Okay, this is the Ohio Trauma Triage required course for recertification. Your presentation, and then a quiz involved with a little bit of self-study that will take it to a 2-hour con ed. You can put Lieutenant Brian Bittner as the instructor for the course when you put it in your drill report. This is the PowerPoint put together by Carol Cunningham and the director of EMS for the state. This will get us what we need to do your research in your 3-year cycle. The objectives of the course are the legal definitions of trauma triage, which is the whole purpose of the course. They want everyone to understand that trauma triage and trauma transport are laws and there's legalities behind them. And if we don't follow them or deviate from them, we have to have a reason for that. That's essentially the gist of the entire course, is to basically cover yourself if you don't follow the law. And then the point of the program is so that you know the law and have been trained appropriately in the law every 3 years. So learning objectives are just obviously the legal definition. Discuss the definition of what a trauma center is, and that's just knowing what we have in our area and the different levels. We really only have 2 that we deal with, and we pretty much know what to do to make it happen. So that's not something that's very difficult for us to figure out on the definition of a trauma center. We don't have one in Lake County. We do know where our level 1 and level 2s are, and we do know how to access them. And then just list the anatomic criteria to use when you're evaluating in the different level of trauma victims. For pediatric, adult, and geriatric, there's a couple different criteria for each one, and they each have their own range of what would trigger them to be a trauma victim. Mechanisms of injury and special considerations are things that don't automatically trigger, but things to be taken into consideration. And then the big thing is the 5 exceptions for transporting trauma patients directly to centers, up to and including us hitting a local hospital and then having them flown to a trauma center. That is part of one of the exceptions. Just a quick background. It's the leading cause of death for people age 1 to 44. The risk of a severely injured patient is 25% lower when they get to a level 1 trauma center, which is our goal for someone that meets the criteria for a trauma victim. The legal definitions established by the Ohio Revised Code, and they're amplified by state boards and agencies. The Ohio Revised Code, so the state EMS board, basically gives recommendations, and then the General Assembly turns it into law, which has already happened. They define traumatic injury, what a trauma patient is, what trauma care encompasses, what a trauma center must be, and how trauma triage must be practiced. So basically that's the biggest part of us, is the trauma triage part, what we practice and how we have to go about it legally to meet the law. Legally defined as those who have sustained traumatic injury, legally defined as damage or destructive tissue that satisfies both of the following conditions, and it's got to pose a significant risk to one of those 4 factors: loss of limb, loss of life, and it has to be caused by blunt or penetrating injury, electrocution, drowning, suffocation, burns, that kind of stuff. So it's got to meet both of those criteria. So trauma care is legally defined as the assessment, diagnosis, transportation, treatment, rehabilitation of a trauma victim by EMS, where obviously the biggest part is the assessment and the transport and treatment for meeting the legal requirement we have to meet. The hospital designated as a trauma center by the state of Ohio when it gets these certifications, and again, they're not super important to know all those reasons. We just have to know who's capable of what and get the patient to the right trauma center for the treatment that they need, that will give the best patient care and meet the requirement all at the same time. So Ohio Prehospital Trauma Triage rules. Trauma centers of hospital has immediate availability of specialized surgeons. All this stuff on a 24-hour basis, and then the different levels are basically just the different capabilities of that hospital, what they have there, and then it goes beyond that into education and other things that create a level 1, level 2, and level 3 trauma center. The reasons to take seriously injured patients straight to a trauma center, obviously, is they have the capabilities to deal with these things that Lake Health can't, that Geauga can't, that other hospitals outside of the trauma designation cannot. Level 1 through 4 in Ohio, based on the depth of resources again, on the ability of, them to get someone into surgery in a certain amount of times. It's not about the quality of care. So level 4 and level 5, or level 1 rather, should have the same quality of care, but they might not. They definitely will not have the same amount of resources. So level 1, we have Metro, that's our main level 1 in the region. It's a trauma center most of the capability of providing total care for every aspect of the injury. So they have to have trauma prevention education, they have to have the rehab services, they have to be a leader in education and system planning and all that stuff. That's where Lifelike comes in. But that's a level 1, and that's obviously our center's Metro. Level 2, pretty close to a level 1. We know ours is Hillcrest. That we're primarily going to take people ground transport wise. We do a lot of that going there. They assume responsibility for education and system leadership, where a level 1 trauma center does not exist. Now we have 1 and 2, but they both do education and put out a lot of stuff for training wise and stuff in the area. Both Hillcrest and Metro do. We probably get more from Hillcrest. Level 3, served communities don't have immediate access to 1 or 2, so that's not us, so we don't have those. And level 4 even more so. You're looking out in like rural areas where it's just quick advanced life support before they can have air transport. And again, we don't really deal with that in Lake County. So the law requires that all trauma victims be transported directly to a trauma center. That's the law. That's the simple long and short of it. But then our biggest protection is there's 5 exceptions to that law, that if we don't do it and we meet one of the 5 criteria, which we pretty much always can, and we document it, we will be covered legally. And that's, again, maybe the biggest point of the Ohio Trauma Triage law and the training, is that we can't get someone to one of these centers directly on a ground transport. We give the reason why we can't, and it's legitimate, which we have several of them are legitimate in probably every scenario that we have a trauma. Then we're covered under the law. So just the adult trauma centers in our area. We have Metro, Akron. Now obviously we're not going to drive very frequently to either of those, certainly not Akron, but that's where a lot of the people we fly will end up, either Metro or Akron. Hillcrest is our level 2. We can do a lot of ground transport there, and some of our air transports will go there. And I'm sorry, Geauga is a level 3. I forgot that happened a few years back. But we're obviously not going to go out of our way to transport a trauma to Geauga for a level 3 and go further than we would for a level 2. We have a Pediatric Trauma Center level 1, Rainbow. So we can send any pediatric traumas by helicopter to Rainbow. And Metro is also a level 2, so again, they can triage that. Once the helicopter is called, they'll decide where they're going to go with the pediatric victim. They may even end up in Akron. This is from the EMS manager at the time from Hillcrest. Just an intake form showing what they do when you trigger a trauma alert, and they want you to say that if you're going to transport to Hillcrest by ground. They want to let you know. They want you to tell them that you're coming in with the trauma, and that'll trigger them to start this process here, assemble teams, and have people waiting for you on the ready when you get there, get people ready on floors and different stuff like that. So this is the form that they use when you call in and say, I have a trauma alert. Obviously, one of the biggest things is the complaint and mechanism of injury, and a good set of vitals up top, and then the assessment's big for them. They're going to want to know a lot about the patient assessment, a lot about a physical exam, so they can see what they're looking looking at dealing with when they get in. They can know what resources they may need triggered in the hospital outside of the ER for when you get there and beyond the first hour that the patient may be with them. They don't handle burns, isolated eye injuries, implantations, of amputations, or pediatric trauma patients less than 16 years of age. They do have a PEDS ER, but it's not a PEDS trauma ER. So it's a mistake I think a lot of us think is that we can take a pediatric trauma to Hillcrest. Now we could have them flown, and they're probably not going to go there, or we can take our pediatric cases there, but they don't do pediatric trauma. It's just something I think that's a common mistake we all think. Just from 2013 mechanism of injury stats, let's see. Men get hurt with blunt trauma the largest percentage of the time. It's mostly younger adults that are active and doing things to cause themselves to fall and be injured or be hit or whatever the case is, being in fights, being aggressive. That's where the trauma comes from. We see that a lot. Motorcycles, vehicles, high speed, risky type leisure activities cause the most trauma, so that makes sense that that's the age group. Obviously, outside of that, there are the seniors that fall and are a trauma of their own, but that's not exactly what we're discussing in this. The trauma patient, trauma victim definitions. So, a pediatric, I think classically you always think 0 to 18 legally, but as far as healthcare goes, and trauma in particular, it's 0 to 15 years of age. Adults 16 to 69, and then your geriatric adults are 70 or older. But if you have, adults that are late 50s, early 60s with maybe advanced disease processes and things like that, or just terrible shape or whatever the case is, and it's an unknown age, you can consider them a geriatric probably for a lot of this stuff. At the same time, if you have a 15-year-old kid who's huge and you've seen them in a trauma and you don't have their exact age, but they're a large pediatric or a large teenager, and you're thinking they're over 16, you can treat them as adult as well. It's based, if they're going to be a big kid, and a lot of it's going to be based on size when you're on those borderlines. And then just a simple definition of a trauma patient or victim, someone that, again, that poses significant risk of loss of life, limb, significant disfigurement that's caused by blunt penetrating injury, exposure to, electrocution, chemical, radioactive, burns, all that stuff that we discussed in the first couple slides. So it's got to be that type of injury that's caused by one of those factors. Just quickly, the body regions. For assessment, they're divided into these 6 areas. And that's when you're doing your assessment. When we looked at that Hillcrest sheet, they want to know specifics on each of these areas, whether there's anything positive or negative for injury or potential for, loss of limb, stuff like that. Evidence of hemorrhagic shock includes any of the following. We know all these: the delayed capillary refill, the diaphoretic skin, altered level of consciousness. So the evidence of neurovascular compromise, the 5 Ps, we know those. Make note of that, use it in your physical exam. The evidence of poor perfusion means one or more of the following things. So any one of these would signal poor perfusion and thus potential shock. Or the weak distal pulse, the paleness, cyanosis, the cap refill again, and the tachycardia. Based on the patient's age, obviously the pediatric heart rate's going to be higher. Evidence of respiratory distress includes all the things we know. We deal with them all the time on asthma and difficulty breathing calls, same type of stuff, but if it's not supposed to be there and it's secondary to trauma, it's obviously another sign that we're looking for. And then the traumatic brain injury, which is one of the most difficult ones for us to deal with, but one of the ones that we're always looking for, probably most prominently in any trauma for sure. And we know all the different signs and physiological indicators that we look for on many calls. Anytime we hear head injury, we look for these things. So we can quickly assess someone's potential for brain injury with the same things that we would anytime we have a fall or anything else. Just for definition signs, proximal long bone, the humerus or femur. We all know that anatomically. Seatbelt sign, which is something to use as a consideration. Actually, it's a trigger for considering someone a trauma patient has bruises or abrasions of the chest, abdomen resulting from use of seatbelt. It says that they had a significant mechanism of injury, which is obviously one of the triggers. And signs of symptoms of spinal cord injury, which is obviously a large consideration for us. Paralysis, weakness, numbness, and tingling, things that would potentially signal us to take further precautions than we currently do with every single little fall. We do the backboarding like we used to do, but if somebody has the signs of these things, we take a lot more precaution, especially in an actual trauma with a serious mechanism of injury. When evaluating an injured person for a trauma triage center, we must look for certain indicators of serious injury, and the indicators will be anatomic, physiologic, the body's response to the injury, or mechanistic, the cause of injury. So the injury suffered, the body's response would be, the pallor, the cyanosis, the shock type signs, and the mechanism is the cause, the death in the same compartment, falls of over 20 feet, things like that trigger us to say this is a trauma patient that needs a trauma center. If they're found to have any of those indicators, they're required to be transported to a trauma center, again, outside of the exceptions. There's also special circumstances, burns, stuff like that. They're going to go to Metro. Pediatrics, they're going to go to a pediatric center, things like that. And there's different indicators for pediatric, adult, and geriatric. A fall of 20 feet for a 25-year-old is a lot less of a deal than a fall of 20 feet for a 71-year-old. So things like that will make a difference. Two long bone fractures, things like that mean more to a geriatric. Burns over percentage areas of a pediatric patient are a lot bigger deal than a 35-year-old. We all know that there's different indicators for the different age groups, which is why they exist, just for us to make a more educated and intelligent decision on who needs to go. So if anyone has any of these following indicators, they should be directly transported to a trauma center outside of the 5 exceptions, or taken for quick care and flight to a trauma center. So just pediatric, the penetrating injury to head, neck, or torso, that's pretty much going to be every age group. Significant penetrating injury to the extremities with neurovascular compromise. Proximal to the knee or elbow, so closer to the core, so maybe not so much with a hand, but definitely with an upper arm or a thigh. Visible crush of head, neck, or torso, again, that's going to trigger us for all. Abdominal tenderness, distension, or seatbelt sign, again. Seatbelt sign is going to trigger us for pretty much everyone. Flailed chest and a pelvic fracture. Injuries to the extremities with visible crush. Amputations proximal to the wrist or ankle. So again, well, we probably would for a finger or something like that. It's must happen for ones, at the wrist or ankle and above. Fracture 2 or more long bones, spinal cord potential injury, and then definitely burns. And again, with the pediatric, it's over 10% of the body, or anything involving the face, hands, feet, genitalia. GCS less than 13, 5-minute loss of consciousness, can't localize pain, any of the evidences of shock, and respiratory distress and failure, obviously. So adult, they're going to mirror the pediatric exactly. So an isolated hip fracture in adult doesn't necessarily have to happen if someone's, playing a sporting event, something like that, and an adult falls from a ladder. But again, probably would. There would almost be no reason to not take them to at least Hillcrest, but it doesn't then meet the law if it's just an isolated hip fracture. Again, same things with the amputations, the spinal cord, the burns, the area of the burn and the locations of the burn, and the Glasgow Coma score. Pretty much the same stuff. Now, obviously, our pulse rates for shock are going to be different on adults, and our blood pressures, might be a little more unstable in adults, but respiratory and pulses are going to be different for adults than younger peds. Geriatric, again, pretty much mirror the adult. There are a few differences. So injuries sustained to 2 or more body regions. Healthy 30-year-old falls and injures their arm and their knee, they probably don't have to go straight to a trauma center, whereas a 76, 77-year-old falls, possibly breaks an elbow and a knee, that's a trauma. It's a different, just based on their frailty and their ability to cope with injury. Same as far as all the other injuries, the fractures, the amputations, the burns. Glasgow coma is basically the same. So, other than that, less than 15 with a known or suspected traumatic brain injury, we don't want any type of decrease in their alertness or anything like that, just because, again, their lack of ability to cope, and then the blood pressure triggers higher for them, just because, again, the lack of their body to cope with the injury. General mechanism, or more geriatric mechanisms, pedestrian struck by a vehicle. We suspect them for a lot more injury than a younger adult, and the same again, falls from any height. We have the 20-foot threshold on them. It's any fall, including standing, with evidence of any brain injury, again, because they can bleed easier internally. Tissue's not as strong, fibers aren't as strong at their age, so there's a lot more to suspect for any type of fall and trauma from them. So, if they have any of the indicators listed, they have to be transported directly to a trauma center. They meet the criteria, they meet the law. And again, outside of the 5 exceptions, justifying them and recording them, they have to be transported to a trauma center. So we have to be concerned about mechanism of injury and special considerations, but they aren't automatic legal triggers. They're just additional factors in making the decision, and they're probably going to cause over triage, which is the goal of the system. Because if they don't meet any other criteria, but they do have a lot of these additional factors going on, you will take them, but you might not fall under the trauma law. They might not be in the definition legally of the trauma, but that doesn't mean we can't take them, and we are aiming for over triage. So motor vehicle crashes with ejection, rollover, extrication, now we're looking at mechanism of injury and stuff like that, which we do have to look at in the actual considerations under the law, but we come up to rollovers with people sitting outside the car, walking around many different times, and we don't need to strap them down and take them immediately. They do have a choice, and they technically don't meet any of the criteria if they're perfectly fine and want to sign off. Death in the same passenger compartment. We've seen people get crushed and killed on the one side, and the person on the other side gets up and walks away. They should go to the hospital. We need to encourage it, obviously, but it doesn't technically meet the trauma law. Basically, they have no injuries that they're showing. They have no signs. They have no symptoms. Nothing anatomical, nothing physiological showing whatsoever. Evidence of high-speed crash. Again, these are all major mechanisms of injury that we should definitely consider taking someone, but at the same time, they don't meet the exact legal criteria. Any auto versus pedestrian, motorcycle crashes, obviously, again, more serious mechanisms of injury that we're probably all going to end up. We have close access to trauma centers, and there'd be no reason for us to not take them. But someone, again, in a very rural area and stuff like that, may have a lot more reason to not take them. Pregnancy is a good one. Maybe somewhere where there's a birthing center or a OB unit is definitely where you want to get them. And then other comorbid situations where a person has disease processes that make trauma that someone, it's like a geriatric situation. They have a bigger indicator for risk from trauma than a healthy adult. They're not the only reason to decide, but they are supporting reasons, and they may indicate whether or not someone goes even if they don't meet the exact criteria under law. So there's the trauma victim indicators from the Department of Public Safety site, which doesn't even look like this anymore, but it's the same thing. We just went over all this. Same thing, the anatomic criteria, and just the simple protocol and flowchart of where to take them, and they have to be transported to a trauma center. Being that if they don't have every one of these things, they don't meet the law, but that doesn't mean that certain special considerations might not say that they still should go. So here's the big part for us. It's the 5 exceptions. It's the legal exemption for us and the kind of cover yourself thing if you don't do it. Now, first and foremost, there should be a good reason. And we should be treating patients appropriately and taking them to the appropriate facilities, but there are times that we can't. And even our trips to Lake Health to meet the helicopter do meet the exception typically, because that isn't a trauma center that we've not taken them to. We are meeting a helicopter, which would meet the criteria, but that is in one of the exceptions, and we do need to document why and what we did in that situation when we do that. So it requires that a patient be transported directly to a trauma center. So a helicopter to scene is being transported directly to a trauma center because they're picking the patient up and taking them. We're not doing the transport. So here's our 5 exceptions. It's medical necessity for initial assessment and stabilization. That's oftentimes why we do go to Lake Health. We have, say, a 10 or 15 minute wait for life flight, and we need to get someone in a more stable environment where they can have better assessment than we can do in the field. So we're either driving 25 minutes to Metro or meeting them at the hospital and cutting the transport time in half and getting number 1 established in here for the initial assessment and stabilization at a tertiary facility. Unsafe or medically inappropriate due to adverse weather conditions or excessive transport time. We can meet that one pretty regularly. We do have Hillcrest that's in very reasonable driving range, so that pretty much takes 2 off the table for us a lot of time, but we do have weather conditions that can change that a lot of times as well. On a good day, it can be a 14-minute ride to Hillcrest. On the wrong winter day, it could be a 45-minute drive to Hillcrest. Cause a shortage of local EMS resources. We can pretty much meet this any day, any time. 2 in the morning, we have 1 squad out. I mean, we may not be able to justify that one, but midday when we're running 3 or 4 calls at a crack, that one probably would almost always hit for us. No trauma center is able to receive and provide care to the patient without undue delay. That's Hillcrest is on full diversion for trauma or something like that. And obviously we're going to, then again, use life flight more than likely and meet them at one of the Lake Health facilities and have them flown to wherever it need be. They go as far as Pittsburgh if they're full around here. And then before patient transport begins, patient requests transport to a hospital to a non-trauma center. It's kind of be the opposite of what we see a lot of times, but if someone's going to say, nope, I don't want to go downtown, I don't like Metro, take me to Lake Health, or take me to Geauga, or take me to, well, that is a trauma center, but take me to a Hoosier or somewhere that's not a trauma center right now, they get to choose that. We would obviously implore them to go to the trauma center, try and talk them into it just like we try to talk someone out of signing off when we don't believe they should sign off. You should go to a trauma center. This is why you have to go. We got to get you there, and this is the reasons we want to talk them into it. But if they have their own reasons that they're making A&O times 3 and they're adamant about it, we can't force them to go somewhere they don't want to go. So just kind of on the exceptions, there must be legitimate, immediate, life-threatening reasons why they have to go to a hospital first. So unable to maintain an airway is an easy trigger. Traumatic arrest, now you're not dealing with the trauma anymore, you're dealing with the full arrest. Secondary to the trauma, that's obviously got to get stabilized first or none of the trauma care matters. Uncontrollable external bleeding. We've tried everything we can. You can't take someone that far, they're going to bleed out before you get there. So protocols provide guidance on this, and we have all those at Lake Health that that address all of this. Unsafe, medically appropriate due to adverse weather. Again, the patient may be better served stopping at the nearest hospital, which is, again, probably a lot of times in winter we're going to meet this. Air transport, boom, there it is. That's the one we use most of the time. It's a professional judgment thing. It's going to be hard to question someone. If you look back at a weather report on the day you decided to do this and it was dumping snow, or it was icy, or it was any reason, everybody understands how the roads work. This is going to be a tough one to argue against you if the weather was adverse that day, if you make the right call.
Things have given us a lot of trouble in the past. Does anybody need anything off this guy, or can we bypass him?
I think Leroy needs something from this guy.
Oh, he needs those devout shoulders? Isn't he a paladin?
Yeah, but that'll help him heal better. He'll have more mana.
Christ. Okay, well, what we'll do, I'll run in first, gather up all the eggs so we can kind of just, blast them all down with AoE. I will use Intimidating Shout to kind of scatter them so we don't have to fight a whole bunch of them at once. When my shout's done, I'll need Anthony to come in and drop his shout too, so we can keep them scattered, not to fight too many. When his is done, Bass, of course, will need to run in and do the same thing. We're going to need Divine Intervention on our mages, so they can AE, so we can, of course, get them down fast, because we're bringing all these guys. I mean, we'll be in trouble if we don't take them down quick. I think it's a pretty good plan, and we should be able to pull it off this time. What do you think, Abdul? Can you give me a number crunch real quick?
Yeah, give me a sec. I'm coming up with 32.33, repeating, of course, percentage of survival.
Oh, that's a lot better than we usually do.
Alright, chums up.
Ready, guys?
Let's do this. Leroy Jenkins!
Oh my god, he just ran in. Save him!
Oh, geez, stick to the plan!
Oh, Jesus. Let's go.
Stick to the plan, chums.
Stick to the plan!
Divine intervention.
Hurry up.
Shout.
He's saying I can't cast. I can't move. Am I lagging, guys?
I can't move. What the hell? I can't hear you. Oh my god.
The eggs keep spawning. More responding.
I don't think you can cast with that shit. Oh my god. Shout.
We got him.
Take it off. I got it. Take it off.
Come on, stay down.
Oh my god.
God damn it, Leroy.
God damn.
Alrighty, continuing just on the exceptions to transport, we went over weather. It's obvious and usable very frequently for us, easily justifiable if it's appropriate. Would increase a shortage or cause a shortage of local resources. So many have limited resources, equipment, personnel. We're a little less limited than a lot of places. Obviously, if most of the other cities around us have one squad out, this qualifies. If we have a few out, we could easily justify it. If we're the only squad out, it's probably a little more difficult for us to justify than Eastlake or Willowick or Wickliffe, where they have one station, 2 squads, 6 guys on duty. They have 4 committed, you know what I mean, and they need a quick turnaround and they have other calls coming in. Easy for them to justify. We can justify this, even with the 1 squad. We all like to say we're low on staffing and stuff, but it's going to be a little harder than a smaller community to justify 23, 24 guys in the city, why 3 couldn't transport to a trauma center, including callbacks and all that. But it is there to use if it's appropriate, not to be abused, just to get out of a long transport. Again, we should be treating these people and doing the right, picking the appropriate facilities for the best patient care, not just to make up reasons to not go. So no trauma center is able to receive. This is an easy one because you're going to get told if you're calling Hillcrest to go there, they're going to tell you, we can't take your patient, and then they've justified it for you. If you get diverted, obviously you're taking someone critical and want to go to Hillcrest, and they're going to divert you to Akron. They're not going to go to Akron, and they just gave you a real easy, justifiable, documentable exception. And then this is another one. Competent patients have the right to say where they want treatment. Obviously, we should convince them they need to be at this facility and tell them why. But you have to respect the competent, alert, and oriented patient's wishes. Maybe something to document, maybe even get them to do a sign-off like we would a refusal. Not a terrible idea, but not something you have to do either. But if someone's saying they want to go somewhere, and you have the whole crew trying to convince them otherwise, and they insist on they're going there, they're not going to Metro, then by all means you take them where they need to go, inform the receiving hospital what's going on and why you're coming there and what the situation is, so they're as prepared for it as they can get. They're obviously going to try and talk them into moving or transfer them as soon as they get there as well, I'm sure, but again, we can't legally take someone somewhere they're saying I'm not going. That's kidnapping, and we're not able to do that. So use persuasive technique just like we would on someone that shouldn't be refusing transport that we think should go. Same situation here, and document it as best as possible. So they're over triage, under triage that they're looking for. The trauma system wants 0% under triage because someone not appropriately transported to a trauma center may die or have obviously a lot worse outcome if they're not at the appropriate facility. So just like the chest pain protocols and all that stuff, we want to over triage. If it's questionable, take them. If it may not meet the criteria legally, but the special considerations or mechanisms meet, we should take them. So the worst case scenario on an over triage is some overload, unnecessary transfers, inconvenience for the family, but if you're trying to do the right thing and the indicators are there, and again we document appropriately and assess the patient in their best interest, it's going to happen, and that's good. So the under triage, the worst case scenario is someone dies or doesn't get the appropriate care. That's a lot worse than taking someone 10 minutes out of their way and having a little inconvenience for potentially the best possible care. Regional variations, we don't really vary much from the Ohio law. It does allow for changes in the protocol, but they have to meet the state and then exceed them. We don't really have any of that. We kind of follow straight along with the law of Ohio. We have local protocols that guide us, but we don't really overextend the state criteria. This is just how they go about changing or increasing or altering the local criteria, but again, we don't do that. They just have to require that EMS transport trauma victims to trauma centers. They may include any of the five exceptions, but can't create additional exceptions. So they could say you can't use shortage of local resources as an exception, but they can't say you could also use fuel cost as an exception. They can't add them in. They can only pull back from it and make it more stringent. So they could limit you down to 3 exceptions, but they can't make a 6th. So again, we don't use any of this. None of the area systems do. So not something that we even really worry about, but just so that you know, the possibility is in place in different systems, or ours if we wanted to, they could do this. Law requires that there's periodic review. I think the last was 2013, about the time that this PowerPoint was updated, and prior to that I think it was 2009. This is to keep like a quality improvement, constant quality improvement of the system. There hasn't been many changes in it in the last decade though. Report review, we do it at a med control level. There's monthly meetings. Lake Health will bring them around. I think quarterly they try to do that as far as getting them out to the stations. I know they do it less than they had, but that's something that we were going to actually start looking at a department level to try and get our report writing better, our documentation better, and make sure that we're appropriately transporting people as well, which I think we do a really good job with here in Mentor. So the question every EMS provider has to consider when evaluating an injured patient is this patient at risk of losing life or limb? And are they at risk for significant disability or disfigurement? Those are the 2 primary criteria in decision making that's going to say this is a trauma, this has to go to a trauma center, and if it's not, I have to say this is why I can't take them there and justify it. The other parts of the evaluation, the respiratory distress or failure, the perfusion, the neurologic symptoms, signs of spinal cord injury and the head injury, neurovascular compromise and an extremity, all are signs that heavily weigh towards classifying someone as a trauma. The considerations on where to transport the penetrating, the crush wounds, the burns, and stuff like that, abdominal distension, pelvic fracture, where's the best place for these people to be? And again, with us, most of the time it's going to be Hillcrest or Metro. So the answer is yes to any of those questions. They have to go to a trauma center. You've met the legal criteria. It's now law that they get transported to a trauma center. Again, just trauma centers provide 24-hour surgical care to allow the patient to be taken directly to the operating room if needed. That's the paramount threshold of a trauma center right there. That's why they need to be there. That's why they have a better survival rate. Their risk of death 25% lower because they have an operating room available with trauma surgeons when they need it, whereas Lake Health or a non-trauma center would not. Again, they don't want to under-triage. We want zero under-triage. Always be highly suspect of injury. If you feel something's wrong, you feel they're a trauma, you feel they need a trauma center, take them. Over-triage is okay. They actually need a 25 to 30% over-triage to ensure that there's no under-triage. All severely injured patients get to a trauma center. They'd rather treat almost a third more people than they should have treated than miss one. And that's the point of the entire system here. So documentation's huge. Accurate documentation of the trauma triage criteria will improve the efficiency of the system going forward. Potentially sway changes in the law, sway changes in the protocols. But that's the whole point. And documentation will cover you, will cover the patient, get them the best treatment, show that you did the right thing in any instance. If you made the right medical decision, you made the right call, you're going to be okay as long as you document it appropriately. So the Lake Health Trauma Guideline is kind of a little microcosm of the entire trauma triage law. It shows you the physical conditions, the anatomic conditions of the patients to consider. We speak to the adult trauma victim being between 16 and 70. So, again, these are just the guidelines that mimic state law and just put into the Lake Health protocol form. Gives you a little more information on the field trauma triage criteria, mechanism of injury, and the special considerations, just like the state law says, the ages, the disease, the comorbid considerations, the mechanism of injury considerations, and then the key points is the exceptions to a mandatory transport. There they are again for us to see so that we use them appropriately when they exist. This is for the geriatrics. Again, the geriatric criteria are slightly different than the adult, and the visual considerations are a little more important with the geriatric. Pediatric anatomic indicators, again, slightly different than the adult. Basically mimic them though. So just a little more specific to peds and a little more useful indicator-wise when determining a trauma. Here's the actual protocols for Lake Health. They have several that would cover trauma patients. We should pick the appropriate one and follow it. Again, to be working under our medical control, this is what we need to be doing as far as treatments and assessments go. So the large bore IVs, 2 preferred. The cardiac monitoring, the boluses and stuff like that, we need to follow our local protocol on that. It's beyond the assessment and people meeting the criteria of the trauma per the Ohio law. This is not how we have to treat them, which is also obviously expected. So there's a multiple trauma, which is going to be just a lot of car accident type injury people. There's the head trauma, which is a little more specific when we have someone with potential closed head injury. The chest trauma, looking at a lot of maybe like a penetrating type trauma and stuff, a little more specific to the chest region. Abdominal trauma, your seatbelts, things like that, other crush injuries. And then you have your burns, which we're going to take. We want to get to Metro, more than likely going to fly them there. But this is how we'd start to treat our burn patients. And then you have your crush syndrome specifically to treat someone that may be experiencing the crush syndrome and how our protocol wants us to follow that as well. And then way more specific is eye injuries and dental injuries. And remember, Hillcrest doesn't deal with eye injuries, so they would need to go to Metro. And dental injuries are something that can result as probably a larger trauma. I mean, if someone cracks a tooth doing something dumb, they're not going to be considered a trauma patient to begin with. But if someone has massive dental injuries secondary to something larger trauma, it's just consideration, and this is the way we should go about treating it for our medical control. That's it for the Ohio Trauma Triage presentation. Remember, take the quiz, complete that and submit it, and review all of the Lake Health Protocol specific protocols. Again, the trauma protocols, review these, know them well. They will be on the quiz. And the guidelines, read through the guidelines, which will just basically recap what we went through on this entire presentation as far as they do mimic the state laws, maybe go slightly further in explaining some things, but basically the purpose of all our guidelines and protocols are to keep us operating in the state law and fulfill the requirement for the trauma triage. So just a quick review of these will take you back over what we did in the slides and then know our protocols. At least know the beginning of them, at least know where to apply them appropriately, what to apply them to. So spend a good 15-20 minutes looking over the protocols and guidelines. Take the quiz and submit it, and we will get you a certification. Thank you very much for listening.